because we really want to know what our patients want to say, and we really want to support our patients' communication. Neither of us has any relevant disclosures. Happy belated World Down Syndrome Day. It was, of course, March 21st, 321. We have several objectives for you today. We want to start by describing some of the medical conditions that impact children with Down syndrome and their communication specifically. And then we want to list supports that can improve verbal communication, but also really focus on total communication, specifically discussing the role of sign language and other augmentative communication, and end by taking some questions. And I'll get us started by talking about the medical portion. So the recommendations come from clinical consensus guidelines that are published at least every 10 years. New ones should come out this year, so watch out. And they're evidence-based recommendations for health screening. They're available free online. They were last published in 2011, and we're looking forward to the new ones. When we think about language and brain development, the easy stuff is stuff like the thyroid. So thyroid hormone is very important in brain development. It regulates cell migration, differentiation, the creation of synapses, myelination. Down syndrome confers an increased risk of congenital and acquired hypothyroidism. This is why we test at birth through the newborn screen or test separately. Know what your newborn screen tests for. In California, it does test for both TSH and free T4, but that's not true in every place. And if you have any concern, especially since kids with Down syndrome get blood work at birth anyway, consider drawing a TSH and free T4 at birth so you don't have to wait 6 weeks to get the results of that thyroid testing. And then you want to test again at 6 months, regardless of symptoms or concern, and then again at 12 months and yearly thereafter. If any child develops any symptoms, constipation, feeding difficulties, lethargy, dry skin, brittle nails, hair loss, any plateau in the growth curve, then test the way you would for anybody who may have symptoms of thyroid disease with a higher index of suspicion. I have found a lot of patients with hypo and hyperthyroidism just by routine screening. If the TSH is elevated but less than 10, you might want to consider repeating in 4 to 6 weeks. The thyroid axis is a little bit different in people with Down syndrome. Sometimes the TSH can be impacted by recent weight gain. If it's over 10 and the child is less than 3, absolutely treat, because that's the 0 to 3 is the time of maximal brain development. Otherwise, you can always consult your friendly endocrinologist, and I definitely do that very often. And shout out to the CHO endocrinologist for bearing with all of my consults. There is no evidence that empiric supplementation of thyroid hormone is helpful in children with normal thyroid function, so we do not recommend empiric thyroid supplementation. And beware of natural thyroid hormone formulations. This is desiccated pig thyroid, and it's popular in some subgroups of the Down syndrome community, but they keep getting recalled. And so, one gets recalled and then a new one pops up, and we can't really be sure of the exact amount of thyroid hormone in each of these capsules. We then want to think about the oral cavity, and there's a lot that goes on in the mouth of someone with Down syndrome. First of all, there's an increased risk of oral aversion, sensory processing difficulties, causing both decreased sensitivity in some parts of the mouth and increased sensitivity in others. Might make it so that you start out a bite just fine and then it feels completely overwhelming as it gets to the back of your throat. Reflux can impact how you feel about having things in your mouth, and of course aspiration into the airway, and we'll talk about that a little bit more in a second. The structure of the mouth itself is different. There's typically a smaller oral cavity, and this changes over time because our tongue is supposed to rest against the top of our palate. Take a moment just to feel where your tongue is resting right now as you're listening to me. It's probably resting towards the top of your palate. That in childhood shapes the palate. And so if my tongue is sticking out because I have low oral motor tone, then that nice palate structure doesn't form, and instead a high arch palate forms, and that will impact the space that one has in the mouth. It will make it seem that the tongue is too large compared to the mouth, and then that can lead to occlusion difficulties. We also have dental issues like dental crowding, extra teeth. The teeth come out in all kinds of interesting orders sometimes. They can be misaligned. And then there's an increased risk of periodontal disease, which can cause discomfort. And discomfort can impact how much we want things going on in our mouth. So a lot to think about in terms of the oral cavity and how it impacts someone's communication. I just want to pause because I hear from a lot of my parents that at some point someone told them that they couldn't breastfeed or shouldn't breastfeed. And I just want to say that breastfeeding is not unrealistic a priori in patients with Down syndrome, as long as there are no medical contraindication. Some kids are born with major congenital heart disease and they just can't handle the energy expenditure of breastfeeding. I understand that. Some kids are swallowing everything directly into their airway because of severe aspiration and they can't breastfeed. I understand that. But if there are no medical contraindication and a parent is willing to put in the work and interested in breastfeeding, then we should absolutely support that, because that work is actually supporting the facial muscles and that will serve the kid really well over time as they're working on their speech. They might need more help though, so make sure you connect them with lactation support, with occupational therapy. We do have some resources on our website. Ultimately, not every kid with Down syndrome will breastfeed, but every mom should be offered the adequate support if she desires it. I want to take a moment to talk about pharyngeal dysphagia. So this is difficulties with the swallow, and that includes just a disorganized swallow as well as aspiration. Some kids may show up with symptoms. They cough when they're drinking. They may sound wet after eating. Maybe they are dribbling milk on the side of their mouth. Maybe they're cheeking it and then spitting it out. Maybe they are sputtering or choking while they're drinking. But it can also be silent, and you might suspect it if there's a history of recurrent infections or unexplained hypoxemia. And it's very common. And I want to show you that in the next slide. So if you have a suspicion for pharyngeal dysphagia, have a low threshold for referring for a proper feeding evaluation that is done by occupational therapists and or speech therapists, and strongly consider a swallow study as that will determine whether there is or isn't aspiration. And the treatment can be as simple as a bottle that paces you better, thickened liquids, feeding therapy. Some children do need to avoid drinking my mouth, depending on the severity. And because the lungs are still developing over the course of the first few years of our lives, and because we know that children with Down syndrome are already at risk for alveolar simplification, chronic lung disease, that pneumonia and respiratory issues are the #1 cause of morbidity and mortality at all ages, it is worth evaluating the swallow, because if the lungs are seeing milk all day long for the first 2 years of their lives, then this can impact long-term lung health. We have to keep a long-term perspective with our patients. The average life expectancy for Down syndrome is 65 years of age. We cannot be thinking about the short term when we work with our patients. This is one study that looks at the rate of aspiration in children with Down syndrome. And what I want to show you is that almost 60% of children with Down syndrome who underwent a swallow study had some degree of pharyngeal dysphagia. That of those who aspirated, 90% did so silently. They were not the kids who were like, they did not show signs of distress as they were drinking, and the aspiration was found because we did a swallow study. And the degree of oral phase dysphagia, so how much there was like dribbling and the stuff that happens towards the front of the mouth, did not correlate with the degree of pharyngeal dysphagia. Have a high index of suspicion for referring and for supporting feeding. Moving back to other things that can impact language, the ears. So we know that because of midface hypoplasia, because of those tiny eustachian tubes and ear canals, we are at increased risk of ear disease. There's also more cerumen usually with keratinized tissue cells that kind of occlude those small ear canals. And then we also know that the immune system of people with Down syndrome works differently, and that can impact our risk of ear infections. In one study, they found that otitis media with effusion was present in up to 2/3 of patients. And fluid in the middle ear canal will cause a mild to moderate fluctuating hearing loss. That means that at any given point, I might not hear everything that you are saying. Most of my patients' parents will tell me, but my kid can hear me. Of course they can. I call their name and they turn. Of course they do. The question is, can they tell the difference between cat and vat and hat and bat? Because if you're not hearing the difference between those letters, because you're not hearing some of the frequencies, then how are you understanding language, and how are you understanding what is being said in context? And most importantly, how are you expected to then reproduce it correctly? And as pediatricians, me included, we're often ill-equipped to know whether there is otitis media with effusion, because those teeny tiny ear canals are just not going to let us see the tympanic membrane for a long time. This studies have shown that up to 2/3 of children with Down syndrome will have some degree of hearing difficulties. The conductive hearing loss is more common than sensory neural, but both are seen. And that hearing impairment due to either type of hearing loss is related to difficulties in comprehension of grammatical phonemes, morphemes, to a significant difference in the number of words produced, and the utterance length, so that how long your phrases are, and speech intelligibility. It doesn't have to be severe or profound to impact language. So what do we do as the primary care doctors? We follow up on the newborn screen, and if the newborn screen was failed, we make sure that they have a follow-up newborn hearing screen. Then we established care with audiology by 6 months of age. This is the guideline by the American Academy of Pediatrics, whether we have concerns or not. If the audiogram is abnormal, we establish care with ear, nose, and throat. If you cannot see the tympanic membranes and the audiogram is normal, consider sending to ENT anyway. They will help with wax management. They will monitor alongside you in terms of hearing. Especially because sound field testing, which is what is done early on, as the kid is not yet able to fully cooperate with behavioral testing and headphones, it will not tell you whether one ear has a little bit of hearing loss, right? And then, can we prevent otitis media with effusion and hearing loss? Maybe a little bit. We can try to help with reflux. Some studies have found gastric juices in the middle ear fluid, and so we can do good reflux precautions, pacing the feedings. We know that reflux is common in kids with hypotonia. We try to eliminate risk factors. This might be another place where we promote breastfeeding. We avoid bottle propping. We counsel on smoking cessation for the parents. Some studies show that in neurotypical kids show that attending a daycare with more than 6 to 8 kids predisposes to ear infections, probably because it predisposes one to be exposed to viruses. So we can try our best to prevent, but if there's chronic middle ear fluid, then we should really think about tubes early on, because tubes can normalize hearing, and having tubes placed actually increases one chance of no longer having hearing loss later on in life. And then considering hearing aids as well. Again, we need to maximize hearing to maximize learning. And since we're talking about the ears, I have to talk about the eyes. Children learn language by connecting a label with an object. And so if I can't see the object, then it's going to be hard to connect a label with the object. Plus, visual spatial processing is usually a strength for kids with Down syndrome. And so if there's a visual impairment, we want to correct that to access that strength. Refractive error and their need for glasses are very common. And I have several patients that are babies that I referred because of the recommendation for routine screening by 12 months of age, who are found to have really high myopia and have really strong glasses that they need to wear. And I don't buy the whole my kids won't wear glasses. You know, I believe in the power of children and their ability to learn. There's strategies for desensitizing to glasses. You need to be the boss of the glasses. So you put them on, and then maybe you're the one who takes them off after just a couple of seconds, and good job. And maybe you're doing glasses during busy hands activities so that the kid doesn't take them off right away, or hypnotizing activities like Cocomelon, you know. I do believe that kids can be desensitized from glasses with the right support. They might need some support from OT or a teacher to get there, but not prescribing glasses because we don't think the kid will wear it just doesn't seem fair. And then I want to talk to you about sleep apnea. Why should we care about sleep apnea? Isn't it just a problem of, you know, older people and people who are obese? Absolutely not. Sleep apnea is associated with decrease in IQ scores. When we are already at risk for cognitive impairment, we better be protecting that cognitive ability. It is linked with behavioral problems and ADHD symptoms. It can cause hypoxemia. It can affect blood pressure and cardiovascular health. It can impact pulmonary health. It can impact one's chance of having pulmonary hypertension, and kids with Down syndrome are already at increased risk of pulmonary hypertension. And it increases one's risk of having abnormal glucose levels and glycemic index and diabetes. So sleep apnea is a real medical issue. In kids with Down syndrome, it's a little bit more complicated than in our neurotypical kids, where it's usually the tonsils and the adenoids that have overgrown. Certainly, tonsillar and adenoidal tissue are playing a role, but then there's also that tongue that is a little too big for the space afforded in the palate. And then as we're falling asleep and the tongue fall backwards, it can further collapse the airway. The airway with the low tone can collapse as we're sleeping. So the size of one's tonsils is not necessarily going to be predictive of sleep apnea. And here's the kicker. There's good studies that look at symptom screening, and they do not correlate with the presence of sleep apnea. So in my patients who don't have Down syndrome, I ask, do you snore? Do you have pauses in your breathing? Yes. Oh, are you having nighttime awakenings? You know, the sleep apnea questions. And I can feel that those are quite predictive of whether someone will have sleep apnea or not. In kids with Down syndrome, I'll still ask the questions. If someone is having overt choking and sleep disruption, I'm going to be really excited about them getting their sleep study right away, but it won't matter. They all need a sleep study, because a child who is quiet when they're breathing can still have pretty significant sleep apnea. In one study that I read of kids with Down syndrome who snore, 100% of them had sleep apnea, and in kids with Down syndrome who didn't snore, 60% of them still had sleep apnea. So this is really important to screen everybody. And you can also ask about sleep position. I have some of my patients who who sleep sitting up or folded over, or they have to be with their neck completely hyperextended to sleep. Those are things that might clue you into the presence of a sleep disturbance. And then in terms of treatment, again, you can try and eliminate risk factors, especially working on weight. You can do saline irrigations and treat allergies. You can consider intranasal steroids and Singulair. Watch out for behavioral side effects with Singulair. I've had several of my patients with Down syndrome who've had them. Do I still prescribe Singulair? Absolutely. I just counsel my patients very well about the fact that if they see a behavioral change in their kid, it could be the Singulair and they need to stop it and talk to me right away. Sometimes in the younger kids, they're put on a little bit of oxygen, and as we wait for them to grow a little bit more and consider more surgical intervention. Oral appliances can be used to expand the palate and create more room in the mouth. Of course, weight loss is really important at all ages. Surgery is often the first step in treatment, but know that tonsillectomy and adenoidectomy will treat the sleep apnea only in 43% of your patients, and that those tissues can grow back in many of your patients. So some kids might need a lingual tonsillectomy or a supraglottoplasty. The point is, everybody needs a post-op sleep study, in my opinion, because if fewer than half of your patients are going to be fully helped by surgery, then we need to know which ones are still having residual sleep apnea and how much. CPAP is incredibly effective, And kids need, again, the support and gradual desensitization to tolerate it. You can use a spacer at first, and maybe you're watching a video and you're pressing the spacer against the kid's face, and then you're taking it off. And then from that, you might graduate to the CPAP mask and then take it off. And then maybe we're turning on the mask. The sensation can be a little strong. Social stories can help. Videos can help. We have support on our website. You will see the benefit even if you wear it just 4 hours a night, 60% of the nights. We're not going for perfection here. And that is something important for parents to know. There's really exciting data on the hypoglossal nerve stimulator. This is an implanted stimulator that goes under the skin, and it stimulates the hypoglossal nerve to thrust the tongue forward and relieve some of that obstruction. Studies in children with Down syndrome are incredibly promising, and I think that in the next 5 years, we're going to see this play a bigger role in patients. And then the last thing I want to talk to you about before I pass it on to Dr. Larroudé is consider whether there's an additional diagnosis in all patients with Down syndrome, and especially if they're struggling with their communication. Autism, as I presented to you at last year's Grand Rounds, is incredibly common in children with Down syndrome, with an estimated 16%, that's about 1 in 6 kids with Down syndrome having autism as well. Of course, it's a challenging diagnosis. There's some diagnostic overshadowing. The developmental delays that exist because of Down syndrome can make it harder to tell apart what's autism and what's not. Some kids have a lot of medical issues that can also muddy the picture. But recognition is imperative because it leads to the appropriate interventions, and those interventions being proffered in a timely fashion. What you might see is lack of sustained joint attention. I always ask if your kid sees a puppy on the street or a plane in the sky, what do they do? You know, do they try to call your attention to that cool thing or something really cool on the TV? And I don't accept the answer, oh, they just go to the puppy. That's not shared attention. The question is, are they looking at you and then looking at the puppy and looking at you to kind of communicate? Let's share attention towards this one interesting thing. They're often more self-directed and have a difficult time engaging in reciprocal play, especially for a sustained period of time. Many of our patients, as Bettina will tell you about, will have a delay in verbal communication, but there's also a marked delay in nonverbal communication, much fewer gestures, a greater delay in pointing. And I accept a pointing with a whole hand. You know, I understand that there might be some difficulty in isolating the index finger because of fine motor difficulties, but some sort of like pointing. I instead see a lot of grabbing of the parent's hand and putting it on whatever they want, which is actually something we see often in people with autism anyway. I've seen a lot, some parents will tell me, oh, they're saying ball and cow. And I always ask them, is it spontaneous or is it upon you saying it and asking them to repeat it? Because the lack of spontaneous communication is going to be an important thing we're looking for. A lot of sensory issues I also see in my patients with a dual diagnosis. Some are a bit hyperactive, although, you know, some of my patients with Down syndrome without autism are also hyperactive. What I see is some inconsistent eye contact. My kids with Down syndrome who don't have autism really use their eye contact in a much more integrated way with their gestures and their communication to really kind of be with me in the moment. And I don't see that as much in my patients with a dual diagnosis. And then a lot of stimming. And kids with Down syndrome will stim when they're tired, okay? Or when they're focused, they might do a little bit of, or a little bit of rocking. But the complex stimming, the stimming that's hard to break, the stimming, the kid who would rather stim than engage with you, or could be broken from the stimming for a second and will go right back to it, is a kid that we should be considering a dual diagnosis for, especially if in combination with other things that I just mentioned. And I just want to acknowledge that my patients with Down syndrome who also have autism are going to look a lot more social than kids with autism alone. And so don't get fooled by that fake sociability that you might see initially. Dig deeper into some of the other signs of autism if you're suspecting a dual diagnosis. You can absolutely use the MChat. You can use the social communication questionnaire. when in doubt, refer for a full evaluation. An ADOS will be done, an ADIR will be done. Teachers and therapists can weigh in. And then the treatments include ABA, some changes to the IEP, some floor time type interventions in terms of supporting back and forth play and symbolic play. And then really making sure that the visual communication modalities are included in one's communication plan. We're not going to give up on speech, of course, but really making sure we're going for total communication. How does a pediatrician refer for speech support? We have a key role in providing information. Of course, you can use our website, charliesclinic.org. We have a whole section on communication. If the child is 0 to 3, then the responsibility is for the regional center to case manage the developmental services through IDA Part C. They are a payer of last resort. The law requires that a child accesses insurance first. Regional Center of the East Bay knows that we don't have a great network of speech therapists. And so for speech, they usually don't create a barrier of having to go through insurance first if the child is on Medi-Cal. And then between 3 and 22, the school district is responsible for educationally based services. And then if a child has medical reasons to also access speech therapy, then the speech therapy can also be available through insurance in addition to the educational services. And I know that there are not as many providers in our area, but I've been working with the various Medi-Cal managed plans to facilitate this. So always consider referring along with a case management referral through the insurance so that the client can be assisted in linking with the service. So with that, I want to pass it on to Dr. Larroudé, who's going to give us some more insight into how to support language through total communication. I will be moving the slides. Dr. Larroudé.
Thank you. Good morning. Thank you very much for inviting me. It's very exciting to be here to share my expertise with the medical community. So before I start talking, I wanted to share that most children with Down syndrome start getting speech and language therapy when they're 18 months of age. They get referred to us for a speech and language evaluation. And usually what parents tell me when I do a speech and language evaluation is that their main concern is that their child doesn't talk and they want their child to talk. So I always tell them that communicating is not only talking. So communication is the process by which one person formulates and sends a message to another person and who receives and decodes that message. So adults communicate with the speech, but we also communicate with gestures, with our vision, with facial expressions, with body postures, with tones of voice. So next slide, please. So we actually communicate through other things besides the speech. So what happens with children with Down syndrome is that usually receptive language is stronger than expressive language. And there is a gap between receptive language is what a child understands, and there is a gap between what the child understands and what the child can say, or expressive language. And so they have communication skills that are greater than verbal skills. So they are very social, they like to get attention, sometimes it's positive, sometimes it's negative, but they like to get attention, so they have higher personal and social skills than their cognitive skills and expressive language skills. And also gestural communication is a strength in children with Down syndrome in comparison to speech and expressive language. And also visual skills are stronger than auditory skills. So if we put all of this in combination, we actually have a child who can communicate a lot, but doesn't have the speech, the expressive language to communicate that. So what do? We work on total communication. We give children a toolbox to communicate. And that toolbox is going to have many different types of tools, so that child can communicate what that child needs and wants, and to avoid frustration, temper tantrums, and challenging behaviors. Next slide. So as I was mentioning, children with Down syndrome, they have a relative strength in vocabulary, so they can learn to label. And they can label through sign language or giving you cards with pictures. And they can also, the verbal language, when they start saying words, they learn to label. And they can label many words, but it's very difficult for them to put 2 or 3 words together. They have relative strength in pragmatics, which is the social language. They can initiate, they can request, they can share information, but they have difficulties in short-term memory and recall. So they have difficulty remember what just happened, and difficulty with verbal information and with grammar. And grammar is how we put sentence together, how we organize words into a sentence. And since they have so much difficulty with grammar, they have difficulties with complex conversational skills. So it's difficult to engage in a dialogue just because they have difficulty putting together all those sentences. And they also, there is a 95% of them will have reduced speech intelligibility. Since they have reduced speech intelligibility, it's very hard to understand what they want to say, especially in connected speech. We have to come up with different tools that will help them be understood and be able to communicate what they want, what they need, what they like, what they don't like, in a very different, with those different tools. Next slide. So this is the general ranges of how expressive language develops. So the first words are usually we have a delay and we don't get the first expressive word between the 2 and 5 years of age. So we have some children who start learning to say some simple words at the age of 2, and some children who don't start talking until they are 5 years of age. In English, the high frequency words for children who are young are easier to say than in other languages. So more, apple, shoe, those are very easy words to say in English because they are 1 syllable or 2 syllables, or they can be reduced to 1 syllable and they can be understood. But in other languages, the same words are 2 syllables or 3 syllable words, like in Spanish, shoe is zapato, and that's a very hard word to learn. So kids turn to learn those words in English. So the first 10 words do not, usually between 2 years, 3 months and 2.5 years old. The first use of 18 words is at around 3 years or 3.5 years. And they have a huge vocabulary growth by the time that they're 3.5 years old, 2.5 years old. And then they put 2 words together between 3 and 4 years of age. If children with Down syndrome have difficulty acquiring the expressive language, the way they're using words, and they're outside of these ranges that I just mentioned, or they plateau, or there is a regression, which sometimes we see at around 3 years of age, we have to rule out the diagnosis of autism. We have to rule out hearing loss, like Dr. Spinazzi said, and apraxia, and significant visual issues. Apraxia is difficulty with motor planning. It's the brain, the child wants to say something, sends that information to the brain, and the brain sends the information back to the tongue in a very different way. So next slide. So one thing I want to mention is about bilingualism. According to the last census, 112 languages are being spoken in the Bay Area. Out of those 112 languages, 25% of the adult population is foreign born, like me. So that means that a big percentage of the children that we work with will be exposed to or are exposed to another language at home. So we are the authority figure as professionals when we work with families who have children with disabilities and they are from another culture. So parents usually rely a lot on what we say. So there is a huge myth that says that children with disabilities cannot learn two languages. Well, or that causes a delay or causes a confusion. So there's a lot of research done in Europe and in Canada about bilingualism and trilingualism on children with disabilities. And they know it's been proved that exposing a child, a brain to two languages or three languages does not really cause delays or confusion. So kids with disabilities can learn a second or a third language, and some kids may acquire both languages simultaneously. That means the parents speak both languages at home, if they speak English and Spanish at home, and they're being spoken at the same level, the kid can learn both languages at the same time and it will not cause confusion or delays. And some other children learn the language sequentially. They learn another language at home, and then when they enter school, they start learning the English. It doesn't matter if it's simultaneous or sequentially. They still can learn two languages or three languages. There's always often stronger language. And the main problem that we have right now, especially in this area, is that many children understand the native language, but they don't use it. So they can follow directions, they can understand everything that the parents say, let's say in Spanish, but they don't really use the Spanish, they answer in English. And because the parents understand English too, they are not asking the kids to answer in Spanish. So it is very important that we encourage parents to raise their children bilingually. Given the children, the gift of bilingualism is very important for the children. And cognitively, we know that being bilingual will help children and will really help them in the future with the frontal lobe, with how they are going to perform in school, how they are going to solve problems. There's a lot of research on bilingualism and the benefits of bilingualism, and having a disability does not impede a kid from learning two languages. So parents usually sometimes are being told to not to use English, not to use their native language at home. But what we want is a good linguistic model, and especially with children with disabilities, we want parents to use their native language, their emotional language, because we want a good linguistic model, and so children can develop that expressive language. Next slide. So now I want to talk a little bit about oral motor skills. So Dr. Spinazzi mentioned how the oral cavity develops, and children with Down syndrome are very at high risk for difficulties with oral motor skills for speech, and they also have difficulty with feeding, chewing, drinking, and swallowing. That low muscle tone, the weak muscles, they make all the coordination and all the movements very difficult for them. So postural stability is very important when you eat. You want to make sure that the kids, when they're eating, they have good positioning. You want 90 degrees in their hips, 90 degrees in their knees, to be able to eat and be efficient. So posture stability is very important for feeding and talking. If you have to balance your body when you're eating or when you're talking, you can't really focus on your mouth. The muscle strength, kids have difficulty with range of motion. That's why it's so difficult for them to learn different sounds. It's very hard for them to pucker, to spread the lips, and they have difficulty with the speed and coordination and dissociation. So that means the jaw, the tongue, the lips, they don't move, they move together. So they have difficulty dissociating the tongue from the jaw. So let's say we want to make the L sound. The L sound, you have to put your tongue up and the jaw goes down. Well, kids with Down syndrome have a very difficult time dissociating the tongue from the jaw. And the tongue movement is also restricted, so they have difficulty with tongue lateralization, tongue elevation, tongue retraction. So all of that will interfere with their ability to produce sounds and to chew and swallow effectively. 97% or almost 98% of children with Down syndrome, they have demonstrated dysarthria, which is muscle weakness, speech motor delay, or apraxia. Next slide. Okay, I'm going to show you a couple of videos about how we do oral motor work. The first video, you're going to see a client of mine who could not blow. So most children with Down syndrome usually blow like this. They cannot pucker their lips. It's very hard to pucker your lips for blowing, and we make a lot of sounds when we pucker our lips, like O's and Oo's. And also they have difficulty drinking from a straw because it's very hard to transition from regular sucking to drinking from a straw. So you want to show the videos.
Happy birthday to you. Okay, hold on, wait. Oh, it's okay. There we go. Oh, again.
This is via teletherapy. So I have never met that child, and I was instructing mom to how to use the straw cup, and he was extremely successful at the second time that he did it. Next slide. Oh. So how do we implement language and communication intervention? We usually work on increasing auditory and visual attention. We really want to be very engaging. We have to work on using paralinguistic cues, such as changing the rhythm, the stress, the inflection, the pitch, and the loudness. It is not the same to saying, hi, how are you? As saying, hi, how are you? All of that will make the situation more engaging. So if you have a patient in your practice and changing the rhythm, the stress, the inflection, the pitch will really help to engage with the patient, and it will help to get good outcomes. We use visual input such as pictures, photos, written words, visual symbols, gestures, and signs. This is what we call total communication. And to make things more functional, we want to use functional tasks such as daily activities, routines, and play to build in practice and carryover of new skills. Next slide. So what do? We encourage things such as singing and melody with the speech, vocal play and sound making, non-speech movements and sequences. We want to imitate the sounds the child makes. So if the child says ba, 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 we encourage parents to imitate what the child is saying. So we are working on that reciprocal play, and we accept word approximations. If a child says Ball for ball, that's fine. We give them praising for that. We practice consonant and vowel combinations such as ba, 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 da, 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 ta, 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 ta. We use visual and tactile cues. Children with Down syndrome need to learn to produce the sounds, and we need to use all the channels. We need to use the vision, the hearing, the tactile. So we teach them what we call visual and tactile cues for verbal imitation, such as ba or ka or sa. This visual and tactile cues really help to produce short words and to produce some sentences as well. The verbal routines with gestures are super important. Singing songs like the Itsy Bitsy Spider, One Little Finger, rhyming songs. If the family comes from a different linguistic and cultural background, we need to ask for songs usually that are repetitive and they have a lot of gestures, and they need to repeat this over and over and over. Children with disabilities and children, specifically children with Down syndrome, need several repetitions and many repetitions of the same activity until they learn it. Reading books is super important with repeating lines and predictable phrases. For example, brown bear, moo ba, la la la, the very hungry caterpillar. Those books are going to help the child develop language. Next slide. How do we emphasize total communication? We want to make sure that we use speech, sign language, gestures, and pictures. Total communication, we want to make sure that we use the entire tools, all the tools from the toolbox. There are some voice output communication aids. There is one called Go Talk that they really help children to communicate what they need and what. And we also have a switch. So at first we can teach them to use a switch if they don't use sign language to communicate what they want. As I mentioned before, we use a multisensory approach, the visual, the auditory, the tactile, in order to encourage communication. All of this will help, as I mentioned, decrease frustration and challenging behaviors. Next slide. So these are some examples of verbal imitation. The first video shows a little girl who just began to say a sound. The second video shows a little boy who is imitating sounds, words using visual and tactile cues and signing, and it's the same with the third one. Go ahead, Noemi.
Mira. ¡Pum! Tu turno. Muy bien.
¿Quieres la manzana arriba de la cabeza? ¿Quieres la manzana arriba de la cabeza? Ok, dime. Sí. Ok, ahí va, ¿eh? ¿Estás listo? ¿Estás listo? Dime. Sí. Ok. ¿Cuántos? ¿Dos? Dime. Dos. Muy bien. Two little monkeys jumping on a bed.
Thank you. Sign language. Why do we want to encourage sign language? Sign language is portable. Sign language will help decrease frustration. Sign language will help decrease challenging behaviors. Why sign language? Because there is always a gap between receptive language and expressive language. So if we give the children the tool to use sign language, we'll help them communicate what they need and what they want. Children with Down syndrome usually understand more, so they will need to communicate everything that they want to communicate by using sign language. It is easy to learn and incorporate, and it's easy because children with Down syndrome are excellent imitators, physical imitators. And at first, I usually instruct the parents to grab the children's hands and to do the sign and to repeat the sign over and over and over, and until the kids praise at the end when they learn a sign. And as soon as the child sees how powerful it is to communicate via sign language, they start using it more and more and more and more. And it can really help overcome oral motor challenges because we are taking the pressure from expressive language, from speech, away from it. When parents come and tell me, I want my child to talk, I can see also that the parents put a lot of pressure into their kids to produce expressive language. So sign language is usually very powerful. It's a wonderful tool that parents can use. And it's been, there's a lot of research done that children with Down syndrome who start using sign language, they'll start using language, verbal language, earlier than children who don't use sign language. So what is the myth? The myth is that signing inhibits speech development, which is not true. It's a scaffolding. We use the sign to until the child says the word. It's usually what happens is the child is saying more, the child is signing more, and then when the child starts saying more, they usually say it and use more, and then with time they drop it. It's something organic that happens. The fact that making gestures does not stop a child from developing a speech. How to get started? There are videos that parents can use. There are wonderful signing apps, and we have developed at Charlie's Clinic a signing kit. You are welcome to download it, or you can show it to the parents. It's under communication. We have over 100 signs with a picture and the word. The parents can print them out, and they can post them all over their home, and they can have access to this whole signing kit that we developed with Noemi, a parent and a volunteer of mine. And here are some examples.
How do you say happy? Happy, good job. How do you say mad? How do you say tired? How do you say crybaby? No, how do you say crybaby? Crybaby. ¿Cómo se dice crybaby? ¿Cómo es el chillón? Crybaby.
Noeli.
¿Y tu hermano?
¿Pez? ¿Quieres pez? Dime pez. Por favor. Muy bien. Ahora mírame, dime pez. Muy bien. Pez, qué rico. ¿Más pez? ¿Más? Por favor.
We always incorporate pictures as well as signs. We call it, this is what we call a food menu when they're young. We want to make sure that we have pictures that they can be incorporated in their daily routines. And this is important to reinforce the use of the visual by acknowledging that you understood what the child wants. We try to give a few options at first. We also have this food menu in English and in Spanish in our website and the Charlie's Clinic website, and the parents can download it and use it. It's currently being used by a lot of my families, and it's very successful. Next slide. Here are some examples of how the kids are using the pictures.
Mire, ¿quiere más palito? Ve. Palito, mire, palito, más, más. Tome, démela. Deme la carta, démela. En la mano, démela, en la mano, aquí. Gracias, bebé. Bien. Gracias, mi amor. Va, ahí está. Bien.
¿Cuál es yogur? Yogur. Yogurt. So, ¿cuál es yogur? Acá.
A tu mamá,
Dámela
a tu
en mi
mamá.
mano. Gracias.
So these are These are good examples of the beginning steps of picture exchange communication system. It's a they use a standardized set of images. They are called picture symbols, but when the child cannot recognize the picture symbols, we use regular photographs. And at first we ask them, it's usually being used to request. And at first we are asking them to give the picture in exchange, but then they can put sentences together in those sentences strips, and it's often carried around in a binder with Velcro. It has different pages so children can communicate what they need, what they want. It can be toys, it can be going outside, it can go to going to the toilet, food, clothing items, just to via pictures. Next slide. So here is some example of using
good. Would I want my get a sauce?
Good job, bud.
And lastly, we want to talk about augmentative communication, high-tech augmentative and alternative communication. There are various levels of complexity. Usually is provided by the school. Lately, we have been able to get augmentative communication evaluations for children under the age of 3. It is rare that regional center will approve an augmentative communication evaluation before they turn 3, but parents or professionals or can request the AAC evaluation when they turn 3, because children with Down syndrome, 95% of them will have speech intelligibility issues. I strongly encourage parents to request an AAC evaluation when the children start talking. It has different levels. They can get it through the insurance or the regional center. School districts will also provide AAC communicators. There's one called Go Talk, or they provide iPads with a special program. Touch Chat is one of them that will help them communicate in different levels. And these are indicated for children who have significant communication impairments, especially children who have the dual diagnosis of Down syndrome and autism. They highly benefit from using of AAC, a high-tech AAC. Next. Here's an example.
Want more applesauce.
So it takes a village. I think it is very important that we can collaborate with the primary care doctors and the family members. I know we all have very busy schedules, but in the last few years, I think the fact that Dr. Spinazzi and I are in constant communication with our patients, it has really helped with the whole care of our mutual patients. And also because sometimes I recommend something and I'm not heard the same way that if Dr. Spinazzi tells a parent and reiterates that information to them. So it really helps to work in a collaborative way with a speech and language pathologist and other specialists like early interventionists, physical therapists, occupational therapists, but the partnership really can lead to sharing of resources and to make sure that the families feel that we are really caring for their kids and that we all have the same ultimate goal, which is helping them communicate what they want, what they need, and to be successful in life. Noemi?
Yeah, just wanted to thank you, Dr. Larroudé. This was incredibly informational. I want to remind you of Charlie's clinic. Charlie is our beloved Bert Lubin's son. And every year when I give grand rounds about Down syndrome, I channel Bert's energy and passion, and I want us all to remember him today. This is our team. There's me, there's Mary Beth Finch, our infant development specialist, is also a physical therapist. Rebecca Rice is our new social worker who's starting next week. And then, of course, we have Annika Miller, our family liaison. We are very proud to employ a young woman with Down syndrome on our team. And we collaborate closely with specialists in the community, such as Dr. Larroudé, who's been instrumental in supporting the communication. We absolutely take referrals. You refer by referring to the Down syndrome clinic at Children's Hospital Oakland. And then sometimes the referral needs to get rerouted a couple of times, but don't give up on us. And with that, I know that we're a little bit out of time, but if there are any questions, we're happy to answer them together. I don't see any questions in the chat. A shout out that we appreciate. Do we take referrals from out of county? Yes, we do. We are, I mean, with every insurance, we take the referral, we process it, we ask for approval, and we see what happens. Partnership has been very easy to work with. We've been able to see patients with Alameda Alliance and Blue Cross Medi-Cal. We have been able to see patients with San Joaquin Health Plan. Absolutely. We also absolutely accept donations. This is another question in the chat. If you go to our web, I'm just going to share really quickly. I want to show you our website because this is available to all of you. And it should be used as a research, www.charliesclinic.org. If you want to donate, this was a question in the chat, you can donate here. But I just want to point out, we have a huge communication section here that includes basis of communication development. Of course, we have Dr. Larroudé featured here and how to get speech therapy. We have the sign language communication toolkit that Dr. Larroudé was instrumental in developing. There's some sign language videos, sign language rules, information about oral motor skills, information about a program called Talk Tools. And then further down, there's information about apraxia and dyspraxia, information about AAC, which is augmentative and alternative communication. The Down Syndrome Connection of the Bay Area is an incredible resource. They have a lending library. They have multiple videos that we put here on AAC. And then there's some information about music therapy as well. There's the picture communication handouts that Dr. Larroudé mentioned. There's music therapy videos. And then there's a section on education and IEP support, one on behavior, one on autism, one on sensory support. We're building medical issues handouts. There's information about how to refer. There's information about local support and recreation opportunities. We know that a lot of our kids right now are at home and they've been home for a year and they're bored and they need to move more because they're gaining weight. And there's Zumba sessions and art sessions and information about Special Olympics and Coach Art and so many other resources. So we hope that you will use our, am I not sharing the screen? I wasn't sharing my screen, huh?
No.
Dang it. Well, that was only fun for me. Once again, this was the communication, the part on communication. So up here, development, medical issues, recreation opportunities, and then if you want to come see us up here, it's where it shows you how to refer And on our homepage, there's a button if you want to donate. And sorry for not sharing my screen.
And also for little babies, we have a page, a handout for infant massage that I think for oral motor massage that I think is very crucial because a lot of our families don't start getting services until they're 18 months of age. So that will be a great handout to give. I'm about to post the translated version on the website as well.
And we have it on our website too, your handout. We definitely put it on our website. Yeah. Anytime you have a good handout, Dr. Larroudé, it ends up on the website. And we're adding to it constantly. Any good talk that we go to, we add information. I don't see any more questions. Thank you so much, everybody. Happy World Down Syndrome Day. Thank you, Dr. Larroudé, so much.
Thank you. Thank you. My pleasure. Thank you very much.